Okay. So hi everybody, welcome and thank you for joining us for the Bariatrics webinar. I'm so excited to hear about all that you guys are doing. So my name is Brianna. I am working in the eating disorder field, and I would like you all to start introducing yourselves and let us know what facility you work in and how long you've been working there as well.
Yeah, go ahead.
You can start.
I'm Laura.
Okay.
I'm Laura.
Okay.
I've been with my practice since February. We do all endoscopic bariatrics. We don't do traditional bariatric surgery. And I'm in North Carolina. I haven't been an RD very long, but I love what I'm in. And the reason I got into bariatrics in the first place was that I'm actually a weight loss patient also. I had a sleeve gastrectomy back in 2013. And so I'd just like to share the good news, and it's what I'm passionate about.
Awesome.
That is awesome. I'm Rachel. I am in Tucson, Arizona with a bariatric and foregut surgery practice. I've worked with my surgeons for about 7 years now, but 2 of them have been affiliated with a specific hospital here in Tucson. And we do a variety of the primary bariatric surgeries, but my surgeons are also looking into getting into the endoscopic procedures. So I'll be interested to hear what Laura's perspective is.
I'm Danielle. I'm in Dallas, Texas. Been a dietitian since about 2014. I graduated from the University of Arizona. My parents live in Tucson, so hi. I've been with my hospital. I work for a major level 1 trauma center here in Dallas. I've been with them for just over a year, but I've done full-time bariatrics, mostly with hospitals, for about 5 years. Usually I take on the coordinator role through MBSA QIP. So it's a lot of, I do pre and post-op counseling, but it's a lot of working with administration to make sure that you're meeting all the guidelines and things like that. Only an RN or an RD can be the coordinator for MBSA QIP, which is pretty cool that they let us do that. So yeah, I ran a program here that was one of the highest volume in Dallas for about 3-4 years. And then I went and ran a private practice, worked for 2 surgeons, which was interesting, but not my cup of tea. So then I went back to the hospital side, and that's probably where I'll stay. So we see it all, obviously, in the hospital. I work with 10+ different surgeons. So we only can do procedures, since we're MBSA QIP, that are approved. So we don't do any of the experimental, none of the mini stuff, none of the, nothing like that. Even if someone's paying cash, it has to still meet certain criteria. So we really only see the basics, the sleeves, the bypass, lots of revisions. We have great surgeons here, and I'm a sleeve patient too, 2013. So hi, Laura.
My sleeve sister.
Yay.
I'm Ashley. I am from Wisconsin, northeastern Wisconsin. I work for a hospital system, but technically the bariatric surgeons are private practice, and I've been working for this hospital system for 10 years and 7 years as a dietitian, and I've been working as the one of the bariatric dietitians for that full-time as a dietitian as well. And we do Roux-en-Y gastric bypass, sleeve gastrectomy, revisions for those, and then we do the Orbera intragastric balloon.
Mm-hmm.
Awesome. Well, welcome everyone. Thank you for being here. So what type of work do you do with the patients before and after surgery?
So for me, when a lot of the hospitals I work at have their own clinic, it's a hospital-based clinic. So any patient that comes through there, I'm responsible for as their dietitian. They don't get referred out anywhere else. So I will see them for all of their pre-op consults. Usually it runs on insurance. Some require 6 months of visits, some require only 1. Generally, with all of the workup they have to do, most patients take like 3 months to get through. So even if they only require one pre-op, I like to do more than one because I think it's beneficial for the patient. But I'll do all of that. And then when I'm running the clinic, I do all of this other stuff. I verify their insurance. I submit for authorization. I schedule their cardiac clearance, their EGD. I run the clinic for the surgeon. It's like herding cats when you're working with all these surgeons and they all want their own stuff done their own way. And then I'll see them at the hospital because they'll have surgery at our hospital. And any patient that has surgery at my hospital, I go and check in with them, even if they came from an outside doctor and I didn't see them pre-op myself, then I still check in with them, make sure they're comfortable, see them post-op, know that I'm a resource for them. And then in the clinic side, of course, when they come in to see the surgeon, they usually see them 1 to 2 weeks after surgery, 3 months, 6 months, all of that. I'm there for them every time. Sometimes we just chat while I'm checking them in and getting their vital signs. And sometimes patients want to book individual one-on-ones with me, which I encourage at certain points where they're transitioning through their diet phases. So I do all that. And then if there's any complications that come into the hospital, the surgeons rely on me to see them, update them, talk to them about why the complication happened, if it's nutrition related, and then I will also write their TPN orders for them.
Wow. Sounds like you do it all.
Yeah.
It's a lot. It's a lot. I'm lucky I have a good nurse I work with.
Yeah. So I don't do all of that fancy stuff because we are all self-pay. So no insurance here, which is quite a blessing in itself. But for pre-op, I explain what the diet progression is and how safe it is, why it's for their safety. And then I just go over the pre-op. Our pre-op is not the 2-week liver diet, which is awesome because we're endoscopic, so we don't have to get around the liver. So they just do clear liquids the day before, the day of, and the day after. And then most of them do 2 weeks of liquids, 1 week of purees, and then 4 weeks of soft foods before we clear to regular diet. We do a lot of procedures. We do some revision procedures. We do the TOR, which is the transoral gastric outlet revision. And then we also do sleeve revisions. And their diet progression is a little bit longer on liquids after their procedures. Theirs are 3 weeks instead of 2 weeks, but then we just kind of make it up. But all of them, it's only 8 weeks. So helping them with that, eventually getting to regular diet, giving them a nutrition prescription type thing so that they start them off with the right macro distribution. And then maintenance after a while, so which is always a good thing. But no insurance, no billing, I love it.
That's nice. That's such a rigorous process for so many people beforehand. It's nice that you get to dodge that.
Yeah, all the 6 months or 6 to 12 months of the insurance required RD visits, which yes, is beneficial. Like Danielle said, seeing them as many times before is good if we can get them in before. But these procedures are becoming so popular because so many people are being denied for bariatric surgery that they come to us kind of in desperation. And so it's kind of like when the original or our sleeve came into being and it was like everybody sleeve. Now it's ESG. So quite popular. My surgeon is quite popular in the United States. He has people come from all over. We even had a guy come from Europe. So he's pretty popular in the endo-bariatric community.
And Laura, I'm wondering, you mentioned a little bit of the positives of not taking insurance. Do you feel like there's any downsides to not taking insurance?
That I feel like I'm the screener. So if I'm worried about them having an eating disorder or a psychological disorder that I don't think is conducive for a bariatric procedure, or if they're going to be ready for that long, trying to evaluate if they are good candidates, and instead of relying on a psychiatrist or someone else. So we only have one surgeon, so I get to tell him if I want to work with somebody or not. And I've only had to do that twice. I've only had to say no twice. Just because this is a lot easier recovery. I don't see any eating disorders. What I usually see is somebody who wants to go too fast. And I'm like, it's not realistic. It's, you know know it, you got to work it. It's not a magic pill. And so I've only had to do it twice, but I would eventually like to get a mental health screen at least. He does cardiac clearance from their cardiologist if he's worried about it over a certain BMI. But other than that, that's the disadvantage of the insurance process. Yeah, but the insurance process it's preventative for a lot of these people, as you all know, that they don't get approved if they lose too much weight. They don't get approved if they don't have a comorbidity and they're 38, it's kind of, and then they, it's like the insurance companies don't think about, well, would you rather pay for insulin and, diabetes medications for the rest of their lives, or would you rather they resolve it? So it's just I think they're mean. So. Yeah.
Definitely. Awesome. Thanks. How about Ashley? What do you do with your patients before and after surgery?
So it depends on their insurance and also the procedure for our intragastric balloon that we do, that we don't run through insurance because we haven't really found any insurance that covers it. So I feel like I'm kind of in the same boat as you, Laura, as they don't have any psych clearance to worry about. And so that kind of stresses me out a little bit, but we haven't actually done that many of those balloons. And we haven't had any for a long time, which I'm okay with that, because I find that just because we haven't had as many, it's harder for me to deal with. Like, I just don't feel as comfortable, I think. But I suppose the only way to get over that is just to do more, right?
That's right.
I'll be okay with how it is right now. But for our surgical patients, whether they are using insurance or not, because we do have some that are self-pay, our program requirement is that they have 2 dietitian visits before surgery. So we meet with them at least 2 times, but we do have a lot of patients that have Medicaid, and in Wisconsin, I don't know if everywhere else, they need the 6 months of dietitian visits before the surgery. And so we do that with them. We have a little bit more preoperative teaching that we also do in usually a group format when there's not this pandemic going on. And then after surgery, we meet with the patients pretty frequently, because they actually, at least from what I've experienced or learned of other programs, it seems like our patients come in a lot after surgery for follow-up visits with the surgeon or the nurse practitioner at like 1 week, 3 weeks, 6 weeks, 3 months. It's like they're there all the time. And so we see them for all of those visits as well, just kind of like in a dual visit fashion with the doctor, the nurse practitioner, whoever they're seeing. And then we also run some of the support groups. And so we see our patients at those. Now they're online, but we still see them. Some of our nurses and our exercise physiologists also lead some of the support groups. So we don't do all of them, but we are involved in that. And then we also usually have cooking classes, which are on hold right now, but we would see our patients for that and be supportive with them in that way as well.
How about you, Rachel?
Okay. Similar to most everybody's little tidbits they kind of like take from each program, we also require at least 1 nutrition visit regardless of insurance process before surgery, but we'll follow those insurance guidelines depending on the number of visits that they'll need excuse me, before surgery. And then after, similarly to Ashley's program, we also pair visits with another provider, but we'll do it on more of an interval basis to where we're seeing the patients with the NP or the surgeon. Pardon me. at 2 months, 6 months, and 1 year is when I'll kind of step in and kind of just do an assessment about how things are going with our program. And then also participate in support groups and other pre-pandemic classes kind of sprinkled in there, both pre-op and post-op.
Awesome. Danielle and Laura, I'm wondering, how do you feel like having had the surgery before helps you with your patients and how you treat them, how you talk to them? And do you actually tell them that you've had the surgery before?
Yeah, I do. That's one of the first things I tell them in their pre-op visit. And I've asked all of them, you know, I hope that makes you feel a little bit more comfortable talking to me as a dietitian, because I have had a weight issue before and I understand what you've gone through. I've paid for the Jenny Craig, I've paid for the B12 shots, I've paid, you know, all of the stuff that comes before, all of the trials that you have to do before you are allowed to use insurance to get bariatric surgery. But I feel like it really helps me relate with them a lot better. I also think it helps with my weight bias, which we all know is a thing in our profession. And I think my surgeon appreciates that because it is relatable. And you know, the recovery or the diet progression is pretty similar. The recovery is not. The recovery, our ESG is super easy compared to a regular sleeve, but the diet progression is very similar. So I know what it's like to be on liquids for 2 weeks. Well, with the original one, it was 4 weeks because you did 2 weeks before and 2 weeks after. But now they're there for 2 weeks and they're like, this is really tough. And I'm like, I know this is tough, but it's just 2 weeks. Then you have a week of purees and then you're going to feel like a real person again. And so I'm very open about it because I want people to know that this is something that works if you use it correctly.
I kind of play mine by ear, depending on the patient. Sometimes it seems like it's not going to be helpful to them, or it seems like it's detracting. You know, it's like you're talking about yourself. So a lot of times it does come up, especially when I'm doing face-to-face. I do some virtual and phone for a second job, and so it doesn't come up as much on that side. Sometimes people, you know, patients like to deflect, and so they'll look at me and say, well, you probably don't understand because look at you. And that's when I'll bring it up and say, well, 60 pounds ago, maybe you wouldn't have said that because when I had a sleeve 7 years ago or something like that. I've been on it from both sides. I was a diet tech for years when I was very overweight and I had patients tell me I was too fat to be a dietitian. And then I lost weight and worked really hard, and I would go in and counsel patients when I was on the units for cardiac diabetes, and they would say, what would you know about it? Look at you. And so then I would carry my pre-op photo, and then it does break that wall down, because our job is very difficult talking to people about things that are very personal, and it's human nature to think, well, you don't know what I'm going through. And so, yeah, I do find that helps. I think you can be a fantastic bariatric dietitian without having had surgery or struggled with your weight, but it is a little bit different. Just like somebody who's had cancer, maybe they would be able to understand an oncology patient better. It's never something I would wish on anybody. I didn't want to have had surgery, or, you know, we all have a struggle. But yeah, I find that when somebody will be very nervous and then I'll start talking about my struggle and you just see this shift and they're like, whoa, okay, let me just, and then they just like open up, because a lot of patients are not very honest with you. They're afraid to tell you what they really eat and all that sort of stuff. So it does help. My surgeons know that they can tell patients that I've had it done. The psychologist we work with, his wife operated on him. He had a bypass. So that's really interesting. On the hospital side, they like to market it. They put my before and after picture out there and like, hey, our dietitian used to be fat. And I'm like, okay, I let them do it. But, you know, because I'm comfortable with it. And so, I mean, like I just had a baby 2 months ago, and so my weight's a little higher than usual. So once again, I'll have my patients look at me and go, did your sleeve work? And I'm like, hey, I'm working on it. I'll be back to my healthy weight. It's very interesting. You get a lot of interesting comments when you reveal that about yourself.
Yeah.
Rachel and Ashley, what made you want to start working in the field of bariatrics?
I
Go ahead,
Oh,
Ashley.
okay. Well, when I was in school, when I was learning, like we all did, learning to be a dietitian, it just weight management was something that I was interested in. And then when I started working for the hospital system that I work for currently and started working as a dietitian, I started doing a few different things actually. And I'm still doing all of these other things. I work in the hospital as an inpatient dietitian, which that's ending at the end of the year. Thank goodness. I'm kind of just tired of doing all these things. Not that I didn't like it. But then I also work as a diabetes educator. And then there was one bariatric dietitian in our hospital system for the longest time. She was by herself. And, you can probably realize that that's probably not a very good situation to have only one person know how to do something. And I think probably nobody else wanted to do it. And I was the new dietitian. So here you go, here you do it, which I was fine with because I really liked it. Looking back, was it really the best role for somebody who was brand new? Probably not, but I figured it out. And I'm really glad that I got that opportunity because it really is my favorite thing to do.
Yeah, similar to your experience, Ashley, kind of just fell into it. My hospital was just getting a program together when I was finishing my dietetic internship. And, of course, you're game for anything. You're like, you're going to hire me? Okay, I'll sign up for whatever. And yeah, just same thing, just kind of fell in love with it, even though back then, I mean, it really was not carved out the way it nicely is now with so many program resources. You're really just muddling through and trying to kind of figure out the insurance piece and things like that before the days of a lot of program accreditation and just kind of so many resources available. So it was a little bit bumpy at first, but I've always kind of come back around to bariatrics whenever I've tried different opportunities over the last few years.
Great. Okay, so this question I have been very interested in hearing the answer to. And I know, Laura, you mentioned it a little bit that you don't see people with eating disorders usually. So I recently had a patient in my treatment facility with an eating disorder, and she had gone to get her bariatric surgery. And what had happened was she was screened on the psychological exam, I believe it is. And basically the bariatric dietitian she was working with told me that she lied on all of the answers. So they gave her the surgery. And then it kind of further snowballed her eating disorder. And now she's really, really struggling. But I was able to work very closely with the bariatric dietitian. She was really great in helping her and making sure that she got what she needed. She made sure she had an outpatient eating disorder dietitian. She made sure she didn't talk about any specific weight numbers with her, which was so great. So I'm wondering, what do you do to screen people for eating disorders, and how do you see it come up post-surgery?
So for me,
Right.
so I don't have a formal process of screening for eating disorders, but through talking to their initial visit is about 45 minutes to an hour. So during that visit, if I get any inkling of, a suspicion that they have any kind of eating disorder or any kind of strange relationship with food, I guess you could say, I immediately notify my MD, and I immediately, we refer them out to a eating disorder therapist instead of me, because I don't specialize in eating disorders at all. And so I'm not about to take that role without it being in my scope of practice. So it's not formalized. We are a relatively new company. These are relatively new procedures. So getting things set up like that is important. We've had several discussions about referring to therapists who can assist with eating disorders. It's a little tough for finding them. Most of them are in facilities around here instead of, a telehealth kind of situation or an office visit. So that's tough for us to find. If y'all have resources to how to find therapists that help with that, that would be great.
I usually don't, I mean, I don't ask any specific questions related to eating disorder stuff when I see my patients. Usually the things we talk about would kind of bring that out. All of my patients do have to have a site clearance, and I read that report, and usually that's where they tend to have an actual question where it's a section, patient denies any previous eating disorders. I mean, I've seen probably thousands of patients now in my career, and I think maybe 2 have had some sort of previous, where I'm talking they're now 30, and this was when they were 16, they had binge or anorexia or something like that. I am more cautious. I talk to them about it. I take more time beyond what their insurance may require, to make sure that I'm comfortable with it, and then watch them closely afterwards. I think all of our patients tend to have some sort of disordered eating, because they will go through binge times, they will, emotionally eat, things like that. I have had a few patients who seem to develop an issue after surgery. Some of mine have struggled with, they thought that losing weight would make everybody like them, and they'd find a steady relationship, and then that led to things, and it's kind of an attention seeking behavior. I had a patient who purposely lost too much weight because he wanted to come see me and do these visits and things like that, and so I put him on a weight gain diet. I mean, that was kind of a bizarre one. I had a lady who had psych issues going on that we knew about. She ended up having to get a J tube put in because she just refused to do what she wanted. She actually asked the surgeon, please take this sleeve out of me. And I'm like, we talked about this. This isn't reversible. It's not something you put in and take out. So that one, she had to come back and see our psychologist. She probably had her tube feed for about 6 months, and then everything corrected, and she was fine. But yeah, I don't tend to see that happen, luckily, where I get anorexia after surgery or things like that. But if the patient is being watched, which luckily we have good relationships with our patients, they want to keep coming back in for those visits. Within that first 1 to 2 years, you would kind of see that manifest, and myself and the surgeon would try to catch it early.
So I don't screen for eating disorders officially. Our psychologist would do that as well. But if I do see anything obvious, of course, I bring it up. Anybody on our team, if we see any red flags of any kind, we talk about that as a group, about prospective patients or patients who've already had surgery. I have, I can probably really only think of one patient that I know of that has an eating disorder after surgery, and she actually was not one of our original patients. I'm sure you all kind of know, patients that are like in your program, but your surgeons didn't operate on them. They've kind of moved to the area or something like that. And I can totally see from what she's told me, how she, this problem came up or wasn't really screened for properly before surgery because her care was inadequate, I feel. And so that's probably how this really occurred. But fortunately, we do have a few really good eating disorder centers and providers here in our area. And so she's getting the help that she needs, but definitely beyond what I can do for her, because eating disorders are not my area. And so I'm glad that she's with the people that she needs to be with, but definitely challenging.
Yeah, I'm sure.
Mm-hmm.
Yeah, our program similar. They actually get specifically asked when they do their initial consult with either the surgeon or the nurse practitioner prior to starting the process, and then again kind of assessed during their psychological clearance. So by the time they get to me, usually, just kind of eking out some of those lesser behaviors. I guess I would describe it as not like a full anorexia or some of the higher up in the tier there, but just more specific dieting behaviors or emotional eating or those types of things, work on a little bit more specifically.
Mm-hmm.
Okay. And Danielle, I believe you mentioned this a little bit before, that somebody wanted to start dating again, I believe, with her surgery. So I'm wondering if any of you, how do you talk to patients about maybe like body image issues, or body positivity, body neutrality, or does that come up for you at all?
It definitely comes up. Yeah.
Mhm.
The body dysmorphia is huge. It I actually created a support group and a private Facebook group that is just for our patients, so they don't get the misinformation from the other uh, Facebook groups out there.
Mm,
So they kind of support each other, and they look at, hey, they post their before and afters, which is amazing to me, because then they get a ton of support from the other patients on the bottom. And but the body dysmorphia, I've seen that. Just last week, I had a patient say something about, I looked in the mirror and I didn't see any weight loss. She said, but I saw, my husband's telling me this, and my friends are telling me that I've lost weight and that type of thing. And it's waking them up, is it's almost like we're in that therapy position where we're like, okay, what else can we do to make you see that there is a difference, besides the clothes are falling off, besides, the facial is just coming off. Like, I do all telehealth now. I've almost always done all telehealth. Even before COVID, we were doing a lot of it. I would see maybe 5 patients a week live. So I can see when it's starting to disappear. And, I will tell them, send me a before and after. And I think that when they put that in an email and they see them side by side, that really helps. For some reason, photographs are stronger than mirrors. And so that's what I see in my practice.
It depends. I mean, you get a whole range of patients. A lot of mine don't seem to struggle too much with self-esteem. They're coming in for surgery because they know who they are and they love who they are, but the world won't see them for that. They can't look past that obesity. That's the first thing that everybody registers. So they want to lose the weight so they can just be accepted by society. Most of them aren't seeking it. They'll actually tell me, I'm not doing this because I'm vain. It's like they don't want us to think, oh, I just want to be skinny. They want to feel good and healthy and resolve some of their health issues. Sometimes I do see them struggle with body image more after surgery. They'll get depressed by lots of things like excess skin, or the fact that their life didn't improve drastically just because they're thin now. Usually I will ask them to do visits with the psychologist, because that is very much their field. It can be difficult in bariatrics to know where your line is. I have a lot of patients who cross into psych issues while they're talking with me. And while I might have personal things that I would love to share and tidbits from my own psychologist, I have to like draw that line and be, whoa, I'm the dietitian. I want you to talk to this person about that. But yeah, I agree with the picture thing, because I did that for myself. I remember thinking, my gosh, I had surgery and I paid out of pocket for it, and what the heck, did it even work? And so I had my favorite picture of myself and my husband. I was very overweight when we were married, and so I would always have that up. And just I tell my patients, put it, especially my female patients, we all get ready in the morning. I have a massive vanity mirror. I've got crap all over that, including a picture that I made my husband take of just my stomach with fresh staples when I had my surgery done, to remind myself, where you started, where you came from, the pain, the struggle, whatever it is. And then I have pictures of, my husband loving me when I was that weight. And to see that is really important to me. And I look at it for the love, but also, I'm like, man, he could barely get his arms around me. So sort of issue. And yeah, it really, it puts that in perspective. So I think that's probably the best thing to do with these patients. Well, I'm not, you hear it all the time. Well, I mean, I'm not losing, I lost 10 pounds the first month and now what's happening? Okay, slow it down. And hey, by the way, when was the last time you lost 10 pounds in a month? Can we look at it from that perspective, that before surgery, if that would have happened, you would have been over the moon. And now suddenly, just because, you know, their expectations are out of line with what the surgery can give them. And it gets worse as they get further out. Most are happy that first 3 months. And then as it starts to slow down, they think something's wrong. And then those issues all come up suddenly.
Yeah.
And one of the tricky things I think is this information age that we're living in. I find so many people are comparing their progress to others. And I really like that Laura has that kind of more isolated support group. We have a local one too that's just for a few of the hospitals here in town. And I think when you scale it down and it's not so many outside opinions or so many people kind of throwing out their numbers and their stats and things like that, it's a little bit easier for the patients to kind of stay focused.
Mm-hmm. Yeah, especially when they don't understand why somebody lost 50 pounds and they've only lost 15 pounds.
Yeah.
And you're like, well, the 50-pound person weighed 350 pounds when they started, and you started at 198, you know, so there's that.
Ashley, we can't hear you.
Well,
Oh, there you go.
okay. Can you hear me now?
Yeah.
I don't know. Okay. I find that giving them the realistic expectations right away is important so that they understand, you know, what is a realistic goal for their weight and what realistically, you know, that weight could be at 2 years after the surgery, but then what to expect, you know, 10 years after the surgery too. Of course, we can't predict the future, but just to give them a realistic idea and discussing that their goal weight isn't a certain number necessarily, but where they can feel good, be active and participate in their life, and you know, they can move around without pain or less pain, and their medical problems that they had are improved, but also a weight that they can live life and not be obsessed with, you know, eating perfectly or exercising constantly.
Yeah, I think that's really important. People get very obsessed with like that specific number. I have to be this specific weight or else it didn't work, right? Yeah. Awesome. Okay. So now, does anybody have any success stories that you want to share?
Well, Ashley, I want to tell you about this since you guys are just getting started with the Orbera. We had an Orbera, and Orbera is like 10 to 15% total body weight loss in our statistics. And so this patient, she weighed 335 or something like that, and she's now 223. And we leave our balloons in for 6 months, and then we give them 6 more months of nutrition counseling, and then they can purchase more nutrition visits if they want to. But I've been seeing her for about a year, and I was just blown away by over 100 pounds with an Orbera. And so these things work. It was impressive. But the ESG patients, the sleeve patients, they do very well. We see about a 22% total body weight loss with them on average. And I think, I mean, not to toot my own horn, but I think it's because the amount of follow-up that we do. We see them every 4 to 5 weeks, depending on where I can fit them, you know, because we follow up so often and making sure that they're staying on track. If they get stuck, they can email me. I have no problem with that. And I share food journals with them. We have our own app for food tracking, and I have a dashboard where I can see what they're eating. And I ask them every time, because food logs are very personal. So I ask them, you know, would you like me to look at your tracking and see if I see anything sticking out to me that you could change and that sort of thing. But that Orbera, wow, I was just blown away with it. Yeah.
Well, that's awesome. One of the struggles that we have with the Orbera, and I guess I'm just curious if you do too, is just patients struggling with the nausea so terribly after surgery that we have, you know, they have to get it removed early.
Yeah, we do see some balloon intolerance. We're actually looking at doing a trial with the Spats balloon, which is different and is not supposed to have as much nausea. So we might be starting that after it's approved by the FDA. But yeah, a lot of nausea with Orbera patients for sure. And early removal. But with early removal, because they get that year of nutrition counseling with the balloon, I just keep seeing them for a year. I give them a year anyway. And I've had them get weight loss that way as well.
Yeah, that's great. We offer the year-long program as well with the Orbera. And so they can, continue to come see us as well. I find that at least for the patients that we've had so far, which we haven't had one for a while, like I said, but a lot of times they just tend to not finish the sessions, which is so strange since they already paid for it, but.
Yeah. I have waiting lists.
Oh.
It's insane. Well, I'm the only RD. And so I actually asked him a couple of weeks ago, I'm like, can we get a part-timer in here just to do pre-ops and I'll do all the follow-ups? And he was fine with that. So that was nice.
That's great. Very helpful.
Yeah.
I have lots of different success stories. Probably my two favorites. I had a young man who was end-stage renal and CHF. And it was really hard for him to get to surgery because he was so high risk. He was going to have a sleeve done. His BMI was somewhere around 35 to 38. And initially the cardiologist wouldn't clear him to go under. So we sent him to another doctor because we thought maybe that first doctor was a little old school. You got to kind of weigh the risks, like he's going to die without the weight loss surgery. So he finally got through the whole process. And when we saw him like a year later, you would have thought he was like an NFL football player. He did so great. He was on the transplant list, healthy. His wife and his family had changed all their habits. He was meal prepping for them. It was fantastic. Like you wanted to cry because he was so young to be an end-stage renal. And so, I mean, I haven't been able to keep up with him, but yeah, it changed his life dramatically. And then I had a friend, a lot of us probably don't talk to people about what we do. My friends know I'm a dietitian, but how much do they know about my specialty? You have people you meet who are obese and you want to go, oh, should I give my card out? But that's, no. But he actually kind of came to me about, and we're talking somebody who was 6'2" and 500 pounds. So this is not a small person. And he was quite young, like 26 years old. My heart went out to him. I wanted to help him, but he finally came to me and was asking about like the diet pills. And I went ahead and said, that's not what you need. You need something more severe. And so luckily his insurance covered it. I set him up with one of my surgeons. He had a duodenal switch done, which is obviously what he needed. And he went to an event with us last year. He lost about 150 pounds in a year. And very compliant, no problems. I think he was worried that it would look bad on me if he wasn't compliant. So whatever works for you. But we went to an event that was very crowded, bleacher stands. There's no way he would have fit in those seats before. And he was near tears, just like he looked at me and was like, you changed my life. I never would have been able to be here experiencing this if you hadn't, gotten me to that point, because surgery is so hard for people to come to and personal, and his whole family is morbidly obese, so it was very difficult for him. And a year later his sister came in and had the surgery too. So young people whose lives change. A lot of times we see patients who are past 40 and have been struggling their whole life. And so sometimes when we see these younger ones, I'm like, I get it. It can be kind of tricky where it's like, hey, you're only 18, give it some time. Why don't you try losing weight a different way? But sometimes that's not, they just need to have this done, and to see that life change so early. Those are some of my favorite stories. I used to be so against it for the young ones. It worried me. And I had an 18-year-old man come in and have a bypass. I mean, he would barely look me in the eyes when we first started. And once he lost that weight, totally changed. It helped with his bipolar. It helped with his self-esteem. He got a job. So yeah, some of those, it's amazing. And then I've got the other side where I've got, I think my oldest patient who had a sleeve was like 73 or 75. Man, she did great. She was at the movies 3 days later. She moved her whole life to Florida to be with her grandkids.
Wow.
It was awesome. So yeah.
Kind of similar
Yeah.
to what you mentioned, Danielle, of a patient that lost enough weight to qualify for being on the transplant list for a kidney. And so that always kind of sticks out, you know, in your mind when you've helped people so significantly in that way. We have a group of patients that help other patients. They're called patient champions, and not that they do everything perfect, but that they are, you know, trying and have a help or a heart to help other patients. And so they help at our support groups. They'll meet or talk one-on-one with other patients to support them. And they kind of help run there are actually two patient Facebook groups for our program. We don't officially run them just because we don't have the capacity to do that. But the patient champions kind of help do that to support other patients. And so those people come to mind as well, because you can just see, you know, how well they've done and how happy they are that they want to help other patients.
That's a really good idea. I've never heard of anybody doing that.
Yeah, they really seem to enjoy it and seem to enjoy kind of even just being more involved with our program and having more, you know, contact with the staff and getting more support in that way. And to incentivize it for them, before the pandemic, when we still had our exercise classes, they would get, you know, some free exercise classes, which normally we would charge for those. And so that kind of helped make it attractive to them too. But I think they would do it whether they got anything out of it or not.
Yeah, that's really cool. We see that with our support groups when they were live. We had some people who would always come and really want to share their experience. I'm curious if anybody else at your clinic or your hospitals have RMR metabolic machines that you use.
We don't. That would be
wish.
great. Yeah.
It can be hard to get them to purchase them because they are expensive, but I've had that in my past 3 clinics. And I would suggest that you make a case for it, because especially if you do, we always do medical weight loss in our clinics as well, non-surgical. That tool is amazing. We all know that we use these, you know, Mifflin and all these sorts of things, but I swear it's like blindfolded throwing darts sometimes. And I'm amazed the information you can get from that. I mean, it's just, we use the REE brand by Core, and it's like 10 minutes of breathing into the tube. And it's so cool, the data you get, and then I'll just personalize it to calories, protein, carbs, fat. And one of my favorite pieces of it is it has this little scale that shows slow metabolism, fast metabolism, or predictive normal, because you put in their age, their weight, their height, their gender, all those things that can kind of affect that. And so we all get all these patients going, oh, it's because I have a bad metabolism. And I love putting them on that machine and going, so your metabolism is normal where it should be. I've had like 5 patients who literally have a slow metabolism. But yeah, those machines, they're a little pricey, but it's my favorite thing. Anytime I move, like when I've moved jobs, I'm like, oh my God, you have got to get me one of these because I can't do my work right without it. So yeah, they're really, and even for your surgical patients, I'll put them on it 6 months to a year after surgery if they've stalled out or whatever, and then can really personalize that. And they're always shocked. They're like, oh, I should be eating that much fat or that much carb or that many you know. And so then getting them to track their intake. I've had so many patients come back to me and go, because of you and that machine, I hit my goal. Yes.
Yeah.
I wish we
I-
had
I-
one of those.
I asked for one when we were still in the office. We've gone completely virtual. So I can't have one in my bedroom and a very long tube to wherever they are, but but I've used it in the past. During my internship, one of my rotations had one, and it's just super cool. I love it.
Yep.
Bill insurance for that?
You can. Some won't pay for it. Of course, your Medicare's, Medicaids won't pay for it. I don't think Aetna usually covers it. But it's like 94690 is the code. I have it memorized because I do the billing. And yeah, it reimburses. It's like $225 or something. And then you bill also, of course, your time. So then when I'm interpreting it and doing the actual counseling session, then you can also bill your M&T.
Yeah, that's awesome. That would make, potentially a little bit more attractive, or could justify the cost of it. Because right now we just have a Tanita scale.
Oh yeah, those are good.
Yeah, which, is fine, but I think the accuracy is certainly better with the that's indirect calorimetry, right? That you have.
Yeah. I've put my friends and family on it and they're all impressed. And then it's kind of cool too. I mean, here my mother paid for my college and she's like, I didn't know you could do all this. I'm like, the 4-year degree, Mom, that was pretty expensive for a reason. But yeah, and then you can even, I mean, for like a cash price, most of the doctor's offices will bill it at $25 to $50, and patients are willing to pay that because, I mean, like the hoses that you use, those are like $7 a piece. So you can see you're making a pretty good profit on that. I always tell people I would shell out that money for that information. I do it on myself. I actually did it in each of my trimesters during my last pregnancy to show people, hey, you're not eating for 2. I think by the end of my pregnancy, I was only up like 500 calories a day or something like that. So yeah, I use it myself all the time.
Rachel, do you have any success stories?
Oh yeah, just similar to everybody. I think it's really great to kind of see those changes that people go through, and they kind of realize, those non-scale victories. I know that we all kind of refer to them as. I think it's always a good thing to kind of make a note of those before surgery, because just like others have mentioned, it's easy to kind of say before surgery, I'm not doing this for anything but my health, and I'm really interested in getting off of these medications and things like that. And then they kind of get caught up in that numbers game after surgery, where they get really hyper focused on weight and macronutrients and things like that. And so just to kind of bring that back out and kind of say, well, how has it been going with the number of medications you're on? Or can you think of anything else that you've been doing? So that's always interesting to hear, just those general victories that people are experiencing. I think one of my favorite success stories was a patient who went on to be a group fitness instructor. And she does quite a bit with our local support group that's on Facebook. She'll do Facebook Lives and do little workouts from her home and encourage a lot of the other bariatric patients to kind of get involved. So she's kind of my favorite.
I agree with the non-scale victories. At the pre-op visit, that is one of the questions I ask is, what are your motivations for weight loss besides the number? And then if they are getting to plateaus and getting frustrated and, not realizing how, I'm like, but you've lost 50 pounds. Yeah, but I've only lost half a pound this week. And, so I'll go back to the original note and say, okay, well, here are the things that you were looking for. Have any of these changed? Just like Rachel said, go back and revisit that.
Okay, so I think most of you have touched on this question already. Do you like your role as a bariatric dietitian, and how do you interact with other people on the team?
Well, I love my job as a bariatric dietitian. It wasn't what I was looking to do when I graduated. Since I'd had surgery, I kind of shied away from it because I didn't want people to just assume that that's what I should practice in. But I was like everyone else. I was the new person. The other person hated bariatrics, so that's what I did. And then suddenly I found that it actually worked well for me. So yeah, I love it. It's actually a very difficult and sometimes stressful specialty. You get a lot of people who absolutely don't want to do it, and that's fine. That's why I'm always like, that's okay, send them to me. I love working with these patients. But it's really rewarding, just the littlest things, even if I only have one small victory a month where a patient, you know, comes to thank you. I never thought that as a dietitian I would have patients who would be so thankful for my help, and that's really rewarding. I mean, I have to work with tons of people throughout the hospital, the surgeons, of course, very closely, their office staff. I work with OR schedulers, floor nurses, hospital doctors. Oftentimes those staff, they're not used to dietitians being around quite as often as I am. So I noticed like quickly I had to really like make my voice known, let people know what I was there for. And once they realized that resource, then they came to rely on it. It maybe was a bad idea to give out my cell phone number, because then it was like, oh, call Danielle, call Danielle, call Danielle. But really, I never thought, I always wanted to be that person when I was going through school and my internship. And a lot of times in my internship, I encountered dietitians who, they were just in the shadows. And I was like, aren't you going to call the doctor? Aren't you going to, you know, oh no, you know, I just write it in my note. Well, who's reading the note? Like, doctors don't read notes. We all know that. So I was glad that in this specialty and the hospitals that I've worked with and the nurse that I work with, they're all like, hey, Danielle, get out there and do this work, not like pulling you back, like, hey, you can't do that. You're just a dietitian. That's not something that I hear day to day. They're like, no, you are the dietitian. Now go make a difference.
So I only work with one doctor and one nurse, and that's it. It's just us three. We contract out for an exercise guy who puts things together, physical activity plans together for our patients. My doctor does read my notes. I love it, because we also, the three of us, have a group text, and he will say, oh my gosh, I saw your note about so and so, and we celebrate our patients. So we are just as involved as almost just as involved as the patient is about, you know, attitude, excitement. We have a lot of energy. I think that's required to be a dietitian in bariatrics. You've got to be excited. You've got to be pumped up. You got to get them pumped up. But as far as being rewarding, absolutely. I absolutely love it. You know, I have tissues on my desk because they make me cry all the time when they thank me. It's terrible. I'm like, it's okay. I get off the phone and I'm like, okay, tissues. Because it is, you know, when I did not expect people to thank me. I don't know why, but when they tell you that they have a better relationship with food, or they're more comfortable around food, or just so genuinely appreciative, it's totally worth it. I agree.
Yeah, definitely. I'm going to echo all of that. And I think just with the nature of how the flow works with most of these practices, and especially for those of us that deal with the insurance piece, you have to have a good relationship with the different team members, because everybody's kind of contributing something and coming up with a plan that's going to ultimately help each specific person. So we have a pretty good dialogue in our office between the NP, the surgeons, the psychologist, myself. We kind of do outsource with other team members, and that gets a little bit trickier to kind of have that natural flow. But within the office especially, I feel like it's pretty ironed out.
I think Ashley went quiet again.
Can you hear me now?
Mm-hmm.
Yeah. I just have to unmute and unmute myself, I guess. I don't know. But yeah, I really do like my job, and we certainly work closely together, from the surgeons and the nurse practitioners that we work with, our, care managers, and we have a patient navigator that helps with the insurance, our psychologist, exercise physiologist, counselors, everybody works together. And I think that's one of the things that I actually like the most about working in bariatrics compared to like the other areas that I work in, like diabetes care and just general kind of weight management counseling, is I feel like there's so much more support, and I'm not responsible for everything. Like, I don't have to help you with your exercise. I can encourage you, but I don't have to help you with it at all, really, because we have an exercise physiologist, which I think is great, because I mean, I know how to exercise myself, but I don't think I'm qualified to give out advice about it to somebody else, And so I think that's one of the things that really makes me enjoy my job, because I can just focus on the nutrition part. And that also our opinion is very valued, which it sounds like that, is echoed with all of the rest of you as well, that we're trusted to take care of the nutrition part as the dietitian, versus like I think Danielle, you said just like sitting in the background, which I have, experienced in my internship too, with other, dietitians. And I think it also helps that even in other areas, because the surgeons that we work with are part of a general surgery practice, and just kind of, by default of being around them in their office, the other surgeons see us there too. And I think that helps with their relationship with the dietitians that are in the hospital, because they realize how valuable dietitians are, and they're not, just ignoring our recommendations, that they really do trust us.
Awesome. Okay, last question of the morning. What is one thing that you want other people to know, other dietitians to know, other bariatric dietitians to know about what you do, or maybe about your patients?
I think it's important for all dietitians to know that bariatrics is a specialty. It's nice that it's kind of been recognized by the academy, that we can get that specialty certification now through that test. That, there's a lot that goes into it. It's more than just saying, hey, this is an obese patient, let's feed them this way. You have to know what type of surgery they had. If you're, seeing them post-op in the hospital, I think it's great if you have a bariatric specializing dietitian. You've got to tag them in. Maybe two can work together, if you have a CNSC or something. But I've encountered people who don't think that I have any sort of specialized knowledge because of what I do. And so it's just kind of an education process sometimes. And then also, we all have bias and weight bias and all of that sort of thing. I'm not immune from that because of where I work. But I always remind people that no patient wants to be sitting in my waiting room. Nobody's excited to say, yeah, I'm going to get bariatric surgery. It's their last resort to have somebody hack you open because you can't step away from the chips or something. That's where a lot of people's mind go, that they have no self-control or things like that. And most of my patients, their weight gain has resulted from some sort of trauma, honestly, in their life. And they just can't get back to where they need to be, even though they've gotten past that mentally. To lose the weight is so difficult. So they don't want to be sitting there. All of my clinics, we always make sure that our doors are like frosted, because they don't want to be in a fishbowl where people are walking by. It's like the last thing. And that's why, I have patients who they work for the hospital, they're floor nurses and stuff, and they come to our clinic and have surgery. And that's the first thing I tell them is, I might see you around the hospital. I don't want you to think I'm rude, ignoring you. I'm going to leave it up to you. If you want to talk to me and pull me aside and acknowledge me, that's fine. But everyone around here knows what I do. And if they see us talking, they might, assume that you've had surgery or something. And this is very personal. So, that I think that's important, that people realize just how personal it is, that not everybody wants to share that story.
Correct. Also, I think it's important. I think even amongst dietitians, I think there's a lot of assumption that this is the easy way out. I think that it needs to be more socially, there is a stigma against bariatric surgery still to this day. I feel like it is disappearing over time, but I think, especially as a patient, I've only had, unlike Danielle, I tell everybody, and even my friends and family know, I've had one person give me negative feedback, and that was my own father. He said I cheated. But the thing is I'm like, well, if that's what it took, now, my chance for diabetes and hypertension is lower. So getting that out there, that this is a life-saving thing, not a cheap way to lose weight.
Anyone else have anything that they want to add?
Yeah, I mean, not much different than you both have kind of said so far, but just really kind of in our own profession, kind of helping other dietitians know the extent of what we're really trying to accomplish and help people better their health, as opposed to helping them cheat the system. And just really kind of always want to zero back to my professional kind of network, as far as the science related to obesity as a disease and kind of the repercussions of it over such a long period of time, rather than just a lifestyle choice. I feel like that's still a stigma that you both have mentioned, but still exists. Just trying to kind of unpack a little bit of that.
Mm-hmm.
Okay, can you hear me?
Yeah.
Okay. Yeah, I would say that I agree with everything that you all have said, that, our role is really a specialty, and I think sometimes that's not recognized. Like, maybe it's just seen more as an extension of general weight management, which, I mean, there are some aspects, but there are a lot of things that are very different in the nutritional needs of these patients, and the recommendations of what, they should or should not do, with their surgery is pretty specialized and different from general weight management. And, understanding that, the obesity is a disease, and how we're managing it, and that, the surgery is not an easy way out, nor is it just a cure either, right? It's just the best management that we have. And I think even helping our patients to understand that as well, that, the surgery is not just curing their obesity and they're just don't have to think about it anymore, because that's certainly not the case. And I think understanding that helps you to really grasp that it's not the easy way out, because you still have to manage it every day, and it's very challenging.
Any final thoughts from anyone before we end?
Thanks for putting this together, Brianna. I loved it.
Yeah, thank you.
Yeah,
Thanks.
of course. Of course. Well, thank you all for being here and talking about your knowledge on bariatrics. I definitely learned a lot because I do not have a lot of experience in this field. So yeah, thank you.
Yeah, you're welcome.
That's great.